Indication: Cabometyx, cabozantinib, in combination with nivolumab, is indicated for the first-line treatment of patients with advanced renal cell carcinoma, RCC. Select important safety information. The full prescribing information for Cabometyx includes warnings and precautions for hemorrhage, perforations and fistulas, thromboembolic events, hypertension and hypertensive crisis, cardiac failure, diarrhea, palmar-plantar erythrodysesthesia, hepatotoxicity, adrenal insufficiency, proteinuria, osteonecrosis of the jaw, impaired wound healing, reversible posterior leukoencephalopathy syndrome, thyroid dysfunction, hypocalcemia, and embryo-fetal toxicity. Please see important safety information at the end of this video.
Hello, I'm Dr. Nancy Dawson, a board-certified internal medicine physician and medical oncologist affiliated with MedStar Georgetown University Hospital, MedStar Montgomery Medical Center, and Lombardi Comprehensive Cancer Center. With over 40 years of experience specializing in urologic cancers, I have overseen clinical trials that have helped significantly advance the standard of care in this field. One of the highlights of my career was being awarded the Legion of Merit by the President of the United States of America in 1999 for my 20 years of work in genitourinary oncology at Walter Reed Army Medical Center. I am deeply committed to the care of patients with urologic malignancies, and I am very proud to have been able to care for our men and women in uniform and for the many brave veterans who have fought for our country's freedom. Today, I'd like to discuss the CheckMate-9ER trial data on the combination therapy of Cabometyx plus Opdivo, a first-line treatment for advanced renal cell carcinoma or advanced RCC. We'll discuss the efficacy and safety data from the trial's primary analysis and the latest 5-year follow-up data, including exploratory overall survival outcomes for patients with bone, liver, and lung metastases. I'll also be sharing some exciting updates about this therapy's inclusion on the Department of Veterans Affairs, or VA, National Formulary. Before we dive into the study design for this trial, I'm excited to share some important news. The combination therapy of Cabometyx plus Opdivo is available on the VA National Formulary. As a retired Army colonel and current medical oncologist, I find it incredibly rewarding to see additional treatment options for our veterans. My journey began in medical school and continued through my Army training, where I developed a strong commitment to serving those who have bravely defended our nation. This dedication is deeply rooted in a respect for our veterans and the tremendous sacrifices they make for our freedom. After graduating from Georgetown University in 1979, I served for 20 years in the United States Army, completing my internship, residency, and fellowship at Walter Reed Army Medical Center, where I spent my entire military career. I have been privileged to work at the Baltimore VA Medical Center as an attending physician, and I did part of my medical training at the Washington VA Medical Center in Washington, D.C., as we explore the significant findings from the CheckMate-9ER trial, a large Phase 3 open-label randomized trial that included 651 patients with previously untreated advanced renal cell carcinoma with a clear cell component. In the trial, participants were randomly assigned to receive either Cabometyx, 40 milligrams orally once daily, plus Opdivo, 240 milligrams IV every 2 weeks, or sunitinib, 50 milligrams orally once daily for 4 weeks, followed by a 2-week break. Treatment continued until disease progression or unacceptable toxicity. The median follow-up for the primary analysis was approximately 18.1 months. We'll also review data from the 5-year follow-up analysis, which was carried out after a median follow-up time of 67.6 months, including exploratory overall survival data for bone, liver, and lung metastases. The primary endpoint of the trial was progression-free survival, or PFS, while secondary endpoints included overall survival, objective response rate, and safety. Both PFS and objective response rate were assessed by a blinded independent central review. To better understand these results, it's important to consider the baseline characteristics of the study cohorts, which were well balanced across the treatment arms. Notably, 78% of patients in CheckMate-9ER were classified as being IMDC, intermediate or poor risk. Additionally, 30% of patients had not undergone a prior nephrectomy. Regarding metastases, approximately 80% of the patients had metastases in 2 or more organs. Specifically, 75% had lung metastases, 23% had bone metastases, and 19% had liver metastases. In CheckMate-9ER, the combination of Cabometyx plus Opdivo demonstrated superior efficacy compared with sunitinib. The PFS for the intent-to-treat population was twice as long in the Cabometyx plus Opdivo group, with a median of 16.6 months compared with 8.3 months for sunitinib. The 5-year follow-up analysis shows a similar trend, with the median PFS for the combination therapy at 16.4 months compared with 8.3 months for sunitinib. It's important to note that no formal statistical testing was performed at the time of this updated analysis. Next, let's review the overall survival data. The graph shows an early separation of the survival curves, favoring Cabometyx plus Opdivo over sunitinib. Although the overall median survival was not reached for either treatment group in the primary analysis, there is a 40% risk reduction for patients receiving Cabometyx plus Opdivo. In the pre-planned final analysis, with a median follow-up of 32.9 months, the median overall survival for the combination therapy was 37.7 months, compared with 34.3 months with sunitinib. With a minimum follow-up of 5 years, the survival curves continue to show separation, with a median overall survival of 46.5 months for the combination therapy versus 35.5 months for sunitinib. In the landmark analysis, OS rates with Cabometyx plus Opdivo were nearly 10% higher at years 2, 3, and 4 compared with sunitinib. At the 2-year mark, 70% of the patients on the combination therapy were still alive, compared with 60% for those on sunitinib. This trend continued at 3 years, with 59% of patients on Cabometyx plus Opdivo alive versus 50% on sunitinib. At 4 years, 49% of patients were alive in the combination arm, compared with 39% for sunitinib. Similarly, the overall response rate was twice as high in the Cabometyx plus Opdivo group than in the sunitinib group, with rates of 56% versus 27% respectively. Notably, only 5.6% of patients experienced progressive disease with Cabometyx plus Opdivo, compared with 13.7% with sunitinib. In the 5-year minimum follow-up analysis of overall response rate data, the response rate for patients receiving Cabometyx plus Opdivo remained double that for patients on sunitinib, at 55.7% versus 27.4% respectively. Additionally, 13.9% of patients on Cabometyx plus Opdivo achieved a complete response, compared with 4.6% with sunitinib. Let's now examine the safety data from the primary analysis of CheckMate-9ER. The safety chart displays adverse reactions occurring in 15% or more of patients with the Cabometyx plus Opdivo group shown on the left and the sunitinib group on the right. Lighter colors indicate mild adverse reactions, while darker colors represent more severe adverse reactions of grade 3 or higher. Overall, the combination therapy had higher rates of hepatotoxicity, rash, pruritus, and diarrhea compared with sunitinib. Most of these were grades 1 and 2. For significant adverse reactions, grade 3 or higher, high blood pressure was the most notable, occurring in 13% of the Cabometyx plus Opdivo group, compared with 14% of the sunitinib group. Next, let's review the laboratory values that worsened from baseline in more than 20% of patients receiving the combination treatment in the CheckMate-9ER trial. The most common all-grade lab abnormalities included elevated liver function tests, ALT and AST, and hypophosphatemia. For hematologic adverse reactions occurring in over 20% of patients, the main abnormalities included lymphopenia, thrombocytopenia, anemia, leukopenia, and neutropenia. It's important to highlight that no new safety signals were found in the 5-year follow-up analysis. Now we'll review the exploratory 5-year minimum follow-up data on overall survival for patients with bone, liver, and lung metastases. Although these data are not statistically powered to detect differences between treatment arms, and no formal statistical testing was performed, they provide valuable insights. This information is especially relevant because bone, liver, and lung metastases are common in advanced RCC patients, and outcomes can vary based on the location of these metastases. I'm pleased to see that we have access to the 5-year minimum follow-up overall survival data, which includes subgroup analyses for these common metastatic sites. Notably, nearly 80% of patients had 2 or more organs with metastases in the CheckMate-9ER. Let's dive into the different subgroups. For patients with bone metastases, the median overall survival with Cabometyx plus Opdivo was 34.8 months, compared with 20.7 months with sunitinib. This results in a 34% risk reduction in favor of the combination therapy. Among patients with liver metastases, the median overall survival was 37.6 months with Cabometyx plus Opdivo versus 22.1 months with sunitinib. Here, the risk reduction was approximately 35%. For those with lung metastases, the median overall survival was 47.5 months with Cabometyx plus Opdivo compared to 32.4 months with sunitinib, representing a 25% risk reduction. Last, in terms of treatment continuation, the discontinuation rate due to side effects was 6% for patients receiving Cabometyx plus Opdivo. Specifically, the permanent discontinuation rate for this combination was around 20%, compared with 8% for Cabometyx alone. For additional context, the permanent discontinuation rate for sunitinib was 16.9%. The criteria for permanently discontinuing Cabometyx include grades 3 or 4 hemorrhage, development of a gastrointestinal or GI perforation, or grade 4 fistula, and other serious adverse reactions. Additional safety information about the drug's profile is available at the end of my presentation. Before we conclude, I'd like to also highlight that Cabometyx plus Opdivo is recognized as a preferred treatment option in the National Comprehensive Cancer Network, or NCCN, Clinical Practice Guidelines in Oncology for Kidney Cancer for all risk groups in the first-line treatment of clear cell and non-clear cell RCC. And as a reminder, Cabometyx plus Opdivo is also available on the VA National Formulary, making this regimen accessible to our veterans. This dual recognition by both the VA formulary and the NCCN guidelines underscores the quality and efficacy of this therapy, further solidifying its place as a vital resource in the fight against first-line advanced renal cell carcinoma. This combination therapy demonstrated a balance of data, including enhanced overall survival, progression-free survival, safety, tolerability, and encouraging exploratory overall survival data across 3 metastatic sites when compared to sunitinib. And the inclusion of Cabometyx and Opdivo on the VA National Formulary is a major step forward that may improve access for veterans and help support the management of advanced renal cell carcinoma. This addition highlights the importance of these therapies and reflects the dedication of both Exelixis and the VA to supporting those who have served our country. Please stay tuned for important safety information about Cabometyx.
Important safety information, warnings and precautions. Hemorrhage. Cabometyx can cause severe and fatal hemorrhages. The incidence of grade 3 to 5 hemorrhagic events was 5% in Cabometyx patients in RCC, HCC, and DTC studies. Discontinue Cabometyx for grade 3 to 4 hemorrhage and before surgery. Do not administer to patients who have a recent history of hemorrhage, including hemoptysis, hematemesis, or melena. Perforations and fistulas. Fistulas, including fatal cases, and gastrointestinal GI perforations, including fatal cases, each occurred in 1% of Cabometyx patients. Monitor for signs and symptoms, and discontinue Cabometyx in patients with grade 4 fistulas or GI perforation. Thromboembolic events. Cabometyx can cause arterial or venous thromboembolic events. Venous thromboembolism occurred in 7%, including 4% pulmonary embolism, and arterial thromboembolism in 2% of Cabometyx patients. Fatal thrombotic events have occurred. Discontinue Cabometyx in patients who develop an acute myocardial infarction or serious arterial or venous thromboembolic events. Hypertension and hypertensive crisis. Cabometyx can cause hypertension, including hypertensive crisis. Hypertension was reported in 37%, 16% grade 3, and less than 1% grade 4 of Cabometyx patients. In CABINET, N equals 195, hypertension occurred in 65%, 26% grade 3 of Cabometyx patients. Do not initiate Cabometyx in patients with uncontrolled hypertension. Monitor blood pressure regularly during Cabometyx treatment. Withhold Cabometyx for hypertension that is not adequately controlled. When controlled, resume at a reduced dose. Permanently discontinue Cabometyx for severe hypertension that cannot be controlled with antihypertensive therapy or for hypertensive crisis. Cardiac failure. Cabometyx can cause severe and fatal cardiac failure. Cardiac failure occurred in 0.5% of patients treated with Cabometyx as a single agent, including fatal cardiac failure in 0.1% of patients. Consider baseline and periodic evaluations of left ventricular ejection fraction. Monitor for signs and symptoms of cardiovascular events. Withhold and resume at a reduced dose upon recovery, or permanently discontinue depending on the severity. Diarrhea. Cabometyx can cause diarrhea, and it occurred in 62%, 10% grade 3 of treated patients. Monitor and manage patients using antidiarrheals as indicated. Withhold Cabometyx until improvement to less than or equal to grade 1. Resume at a reduced dose. Palmar-plantar erythrodysesthesia, PPE. Cabometyx can cause PPE, and it occurred in 45% of treated patients, 13% grade 3. Withhold Cabometyx until PPE resolves or decreases to grade 1, and resume at a reduced dose for intolerable grade 2 PPE or grade 3 PPE. Hepatotoxicity. Cabometyx in combination with nivolumab in RCC can cause hepatic toxicity with higher frequencies of grades 3 and 4 ALT and AST elevations compared to Cabometyx alone. With the combination of Cabometyx and nivolumab, grade 3 and 4 increased ALT or AST were seen in 11% of patients. Monitor liver enzymes before initiation of treatment and periodically. Consider more frequent monitoring as compared to when the drugs are administered as single agents. Consider withholding Cabometyx and/or nivolumab, initiating corticosteroid therapy, and/or permanently discontinuing the combination for severe or life-threatening hepatotoxicity. Adrenal insufficiency. Cabometyx, in combination with nivolumab, can cause primary or secondary adrenal insufficiency. Adrenal insufficiency occurred in 4.7%, 15 out of 320, of patients with RCC who received Cabometyx with nivolumab, including grade 3, 2.2%, and grade 2, 1.9% adverse reactions. Withhold Cabometyx and/or nivolumab and resume Cabometyx at a reduced dose depending on severity. Proteinuria. Proteinuria was observed in 8% of Cabometyx patients. Monitor urine protein regularly during Cabometyx treatment. For grade 2 or 3 proteinuria, withhold Cabometyx until improvement to less than or equal to grade 1 proteinuria. Resume Cabometyx at a reduced dose. Discontinue Cabometyx in patients who develop nephrotic syndrome. Osteonecrosis of the jaw, ONJ. Cabometyx can cause ONJ, and it occurred in less than 1% of treated patients. Perform an oral examination prior to Cabometyx initiation and periodically during treatment. Advise patients regarding good oral hygiene practices. Withhold Cabometyx for at least 3 weeks prior to scheduled dental surgery or invasive dental procedures. Withhold Cabometyx for development of ONJ until complete resolution. Resume at a reduced dose. Impaired wound healing. Cabometyx can cause impaired wound healing. Withhold Cabometyx for at least 3 weeks prior to elective surgery. Do not administer for at least 2 weeks after major surgery and until adequate wound healing. The safety of resumption of Cabometyx after resolution of wound healing complications has not been established. Reversible posterior leukoencephalopathy syndrome, RPLS. Cabometyx can cause RPLS. Perform evaluation for RPLS and diagnose by characteristic finding on MRI any patient presenting with seizures, headache, visual disturbances, confusion, or altered mental function. Discontinue Cabometyx in patients who develop RPLS. Thyroid dysfunction. Cabometyx can cause thyroid dysfunction, primarily hypothyroidism, and it occurred in 19% of treated patients, 0.4% grade 3. Assess for signs of thyroid dysfunction prior to the initiation of Cabometyx and monitor for signs and symptoms during treatment. Hypocalcemia. Cabometyx can cause hypocalcemia, with the highest incidence in DTC patients. Based on the safety population, hypocalcemia occurred in 13% of Cabometyx patients, 2% grade 3, and 1% grade 4. Monitor blood calcium levels and replace calcium as necessary during treatment. Withhold and resume Cabometyx at a reduced dose upon recovery, or permanently discontinue Cabometyx depending on severity. Embryo-fetal toxicity. Cabometyx can cause fetal harm. Advise pregnant women of the potential risk to a fetus, and advise females of reproductive potential to use effective contraception during treatment with Cabometyx and for 4 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions are Cabometyx as a single agent, diarrhea, fatigue, PPE, decreased appetite, hypertension, nausea, vomiting, weight decreased, and constipation. Cabometyx in combination with nivolumab, diarrhea, fatigue, hepatotoxicity, PPE, stomatitis, rash, hypertension, hypothyroidism, musculoskeletal pain, decreased appetite, nausea, dysgeusia, abdominal pain, cough, and upper respiratory tract infection. Drug interactions. Strong CYP3A4 inhibitors. If co-administration with strong CYP3A4 inhibitors cannot be avoided, reduce the Cabometyx dosage. Avoid grapefruit or grapefruit juice. Strong or moderate CYP3A4 inducers. If co-administration with strong or moderate CYP3A4 inducers cannot be avoided, increase the Cabometyx dosage. Avoid St. John's wort. Use in specific populations. Lactation. Advise women not to breastfeed during Cabometyx treatment and for 4 months after the final dose. Hepatic impairment. In patients with moderate hepatic impairment, reduce the Cabometyx dosage. Avoid Cabometyx in patients with severe hepatic impairment. Please see accompanying full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Thank you so much for watching this video. I hope you find the information valuable for your practice.